When choosing the right drug for your patient, you should consider many factors, including the patient's history, whether they have valvular or non-valvular AF, their liver and kidney function, and the potential for drug interactions if they're taking other medications. So, how do you decide which drug to use? Well, there are some guidelines to keep in mind when making this decision. As of 2019, NOACs are now recommended over warfarin in patients with non-valvular AF. But NOAC should not be used in patients with valvular AF. This means warfarin is the only option for patients with moderate to severe mitral stenosis or a mechanical heart valve. If you're considering a NOAC for a patient, you should first evaluate the patient's liver and kidney function. This should be reevaluated at least once a year as long as the patient is on a NOAC. These compounds are metabolized in the liver and excreted by the kidneys to varying degrees, so it is important to monitor both liver and kidney health to ensure effectiveness and to avoid adverse effects. For patients with severe liver disease, end-stage kidney disease, or those on dialysis, your best options are warfarin or apixaban. And even though NOACs have been associated with lower rates of intracranial and fatal bleeding, dabigatran and rivaroxaban have been associated with gastrointestinal bleeding. So if your patient has a history of gastrointestinal bleeding, avoid dabigatran and rivaroxaban. There are many drug interactions to consider when prescribing an anticoagulant. Drug interactions with warfarin can lead to a longer time to clot, increased risk of bleeding, and reduced efficacy in preventing clotting. Antimicrobials, acetaminophen, nonsteroidal anti-inflammatory drugs, or NSAIDs, antiplatelet medications, antiarrhythmic amiodarone can all affect the performance of warfarin. The performance of NOACs can also be affected by the activity of other drugs. The bioavailability of NOACs involves P-glycoprotein at the intestines, and metabolism involves cytochrome P450 3A4 in the liver. When drugs that increase or decrease the activity of these proteins, like ritonavir, conazoles, rifampin, or carbamazepine, are taken alongside a NOAC, anticoagulation may not be as effective. So always be sure to check for possible drug interactions before prescribing anticoagulants to your patients with AF. What else should you consider? Well, dabigatran and apixaban require twice-daily dosing, whereas rivaroxaban and edoxaban are only taken once daily, but can cause symptoms of intolerance like nausea, dizziness, or headache. So it's important to factor in patient compliance and preferences into your decision-making as well. Lastly, when starting warfarin for a patient with AF, the patient's clotting ability should be tested at least once a week to monitor its effectiveness and check for bleeding concerns. This is done by testing the amount of time needed for a clot to form in a blood sample. This is also known as the prothrombin time, which is reported as an international normalized ratio, or INR. The effective therapeutic range of warfarin for patients with AF is an INR of 2 to 3. Once the therapeutic range has been reached, testing can be performed less frequently, starting at once a month. One last thing, as of 2019, the American College of Cardiology, American Heart Association, and Rhythm Society guidelines no longer recommend the use of aspirin as an anticoagulant in patients with AF. Aspirin has been shown to offer no advantage over placebo in stroke prevention and is no longer part of the guidelines for the management of atrial fibrillation. So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.